So I'm going to try to make this entertaining. It's, I don't have the funny pictures and the cars crashing and other things that I've done in the past, but we'll try to keep it light, and I'm happy to answer questions at the end. So, when I was putting the talk together and trying to figure out what people really want to know, my first question was, people probably want to know what is VisionScope, because it doesn't necessarily say, okay, this is what it is. The easy way to describe what VisionScope is it's actually the ability to put a camera into a joint in the office. And I started monkeying with this stuff when I was a resident about 12 years ago, and it was a mess. It was an absolute mess. We had to have constant irrigation. Patients didn't tolerate it well. I basically think I said at that time, there's no way this is going to fly. This is going to go down, and it's like the dumbest thing ever tried. And here I am talking about it. And what I can tell you is over the years, the data on this and the work that's been put into it has completely transformed me. And I think it's one of the most innovative things that we're doing in orthopedic surgery at this time, from a patient perspective as well as from a physician's perspective. I mean, I feel that I can offer more of the things that a doctor wants to give a patient in one visit than I've ever been able to in the past. You come in these days, patient gets examined, they get sent to a specialist, they have diagnostics done, then they have to come back to see the doc. The doctor misses that appointment because he's pulled into a hip fracture, then you forget the other reschedule, then it's like been 3 months. So this is how we're getting rid of this stuff, because we're trying to condense all of that information into 1 or 2 visits, and that's the goal of this. And hopefully I'll be able to explain it a little bit better as we go along. VisionScope is sort of going head-to-head with MRIs, right? So the MRI is our imaging technique for soft tissues. People always say, well, doc, I have an x-ray, do I need an MRI? And even harder is when, well, doc, I have an MRI, do I need an x-ray? Well, the answer is yes to both. One gives us information about one thing, and one gives information about another. The MRI, which is visualized here, this is an MRI of a knee. It gives us a lot of great information about damage to the knee. But if it was perfect, then I wouldn't be up here at all. It's not a photograph. This is a photograph. This is a VisionScope, but this shows where there's a tear in a piece of cartilage called the meniscus, which, if you don't know what a meniscus is, it's just a sponge inside your knee that helps protect the cartilage that turns to arthritis. These tears, we probably see 500, if not more, a year, and that's me personally with my partner, Dr. Novak here. Maybe 1,000. I mean, it's unbelievable how many we see. And we order MRIs for most of these. And what happens is once we get the MRI, which looks kind of like this Rorschach test or ink blot test, we can look at it and say, you know what, Doug, you got a meniscal tear, and you're like, what? Wait, I don't see anything in this, And the truth is, we're relying on our experience reading these. We're relying on MRI techs reading these, our radiologists. One of the jokes I always say in my office is when I read an MRI report, it means I've already read the MRI myself. I go down the report and I look at who read it. I don't look at the report. I want to see who read it, because I have a right, he's going to agree with me or he's not going to agree with me. And then if he doesn't agree with me, I call him. So that's an MRI, right? So you don't see everything on MRI. And the way we used to do it is we would get the MRI, we would use our physical exam in conjunction with our MRI, and then if we disagreed with what the MRI showed, we would take you to the operating room and we would put a camera in your knee. And that's the gold standard for everything that we do, because there's nothing better than the human eye. And then when we did that, unfortunately, you get charged with the surgical bill, the anesthesiology bill, and all the equipment that goes along with it. And in this day and age, we know how much that costs. It's astronomical. So what if the day you came in, we figured out that we could put a needle in your knee, instead of giving you a cortisone shot, put a needle in a knee with a fiber optic camera on it, and we say, all right, Doug, you see that? That's a tear. And you're like, yeah, can't argue with that. All right, what do we do about it? Well, this is what we do. Or guess what? You don't need an MRI, you don't need anything, because there's no tear there. You need to do some physical therapy. And there's no question. Here, there's always a question. Okay, I don't see a tear there, so let's try some therapy. 3 months later, you're not better. Why not? Well, you didn't have anything wrong with your MRI. Either you're crazy or I am. All right, well, we'll take you to surgery, and now, yeah, well, I was wrong. You did have a tear. And I've always said, we don't operate on tests, we operate on people. But now we have a photograph. Now we know exactly what we're doing. Is this going to replace MRI? Probably not yet. But it is definitely giving us options that we never had before. So when we look at what MRIs miss, although MRIs are very helpful in some situations, they're very specific and sensitive, so that if they see a tear of any kind, specifically in the knee, yeah, it's going to be there. It's not likely that it's wrong. However, lateral meniscus, which is cartilage on the outside of the knee, on the inside of the knee is medial. This is a fancy word for saying you've got arthritis, and this is another part of the knee that you can get arthritis. 10 to 30%, sometimes 35%, the MRI misses it. So you go along, you have the treatment that we all think is the right thing, and you're not getting better, and the reason is because we missed it on MRI. How about the shoulder? Well, in the shoulder, there's multitudes of things that can go wrong. I mean, the shoulder is the most complicated joint in the entire body. And look at all the things that are in numbers that I hate to admit. 47%, they get it wrong. They think that your normal anatomy, but you actually have a tear. Sometimes it's the opposite. 50% of the time they find something on the MRI, they read it as a positive, you end up having surgery. I go in there and I'm like, you know, honestly, I didn't have to repair this and I didn't have to repair that. You had some inflammation. Maybe that would have gotten better with a cortisone shot and maybe you wouldn't have needed surgery. I mean, that's hard to accept, but the truth is you didn't have an option back then. Now you have an option. So this is what a VisionScope looks like. It's not this big, I'll just tell you that, okay? That's something you don't want to look at if you come into anybody's
Fits in the
office.
box.
It's a pretty small instrumentation. It's sterile. Just like any other procedure, we are very, very concerned about infection because you can get an infection, believe it or not, from a flu shot. I mean, you could get it from any kind of injection into a joint. A cortisone shot or a joint fluid shot can give you an infection. This is sterile. We prep the shoulder or the knee or the ankle just like I'd do surgery. And we do everything. We have a post-op check. We make sure that the one thing, and knock on wood, we have not seen an infection in the history of this product being released. But the reality is it's probably just a matter of time. But in my practice, hopefully it won't ever happen. Very small needle, just like getting a cortisone shot. It doesn't require any messy fluid. We can see everything that we want to see. No anesthesia. So you get a little numbing medication, just like you would if you were going to get an injection. Then we put the needle in. We can hopefully see everything we want to see. And the reality is, can we see everything? No, we can't see everything. Can we see enough to make a lot of decisions? Yeah, we can. And that's the key to it. So I might not come out of one of these and say, look, you got X, Y, Z wrong with you. But I can say, you know what? We did see this tear. I know I have to go in and take care of that. Anything else I see when I'm in the arthroscopy, I'll take care of it at the same time. But you're not going to get better without me doing at least the first part of that. And these are all disposable. Why is that important? Well, you don't want something that's been in somebody else's joint. We throw it away. It's gone. It's a one-time use. And you're the only person who's going to have that in your shoulder. We can't even say that about our arthroscopies in our surgeries because they get sterilized. I mean, there's no way we can make those cost-effective if we had to throw them all away. I mean, that'd be, well, you'd get charged and you would never have surgery because it would be impossible. So that's what they look like. Sterile disposable kit. And the nice thing is you've got a little camera, and for those who have the stomach, I let you watch. You can watch what I'm doing. It's like watching TV and watching somebody in your joint. I mean, you used to have to go to medical school for 16 years to be able to do that. Now you can do it for nothing. All right, so that's how we came up with this. You know, MRIs that don't always show what we want to see. This is a classic meniscal tear that I saw on a VisionScope. We didn't see it on the MRI. And here's the damaged cartilage. You shouldn't see anything. If I'm going to give you sort of a roadmap, when you see some of these images, people said, you know what, they look like I'm on the moon. I have no idea what you're talking about. This is just like a snowstorm to me. If it looks like basically crab meat or doesn't look smooth, it's bad. Just remember that and you'll be fine for the rest of this talk. That's not good. This is fine down here, but that's a meniscal tear, okay? What we can also see with these VisionScopes is damage to the cartilage where you have arthritis happening. And sometimes the real nice thing about this is if you've already had surgery and you're not responding the way we want you to, we can't do an MRI. People are always like, give me another MRI, doc. Well, you can't. You can, but it's not going to give you the information that you want. What it's going to tell you is you still have a problem. Why? The healing process, which can take up to a year, if you repeat the MRI on someone who's already had a rotator cuff tear or a meniscal repair, the radiologist is going to say you have a new tear. And we're going to look at it and say, well, that's not a new tear. That's where the sutures go through, and the fluid's tracking through the sutures. The MRI just can't pick that kind of stuff up. But I can put a needle in and tell you, you know what, it's retorn, or you know what, it looks fine, and you just need to stay the course. And that's a huge advantage, these post-surgical second looks. So it gives you the confidence to know you're going to do fine, you have to stay the course. If it's bothering you a little bit more than the average person, that's okay. That's just the way it's going. MRI contradictions, we see this all the time. There are people in this room who can't have an MRI whether we want it or not. And this is, you know, we've never had something like this that we could offer them. They went straight to surgery. That's difficult for me. It's difficult for Dr. Novak. It's difficult for you because while we can pretty much handle anything we run into when we get into the operating room, you have no idea what you're going to wake up to. Are you wearing a sling for 6 weeks? Are you on crutches for 6 weeks? I mean, you cannot plan your life. You can't figure out what you're going to do with after surgery. You don't know how much time to take off work. So you had no information, and that's very difficult. If you have a pacemaker, you can't have an MRI. If you've had shrapnel from the military, you can't always have an MRI. And some people are claustrophobic. That's a real problem. You know, I've been in an MRI. I don't ever want to be in an MRI again. It is very claustrophobic. So at least we have an option. And I'm going to show you a case in a second of someone who was exactly that person. So knee, shoulder, and ankle, these are the joints that we're doing currently. We probably would need a needle that goes from here down to the floor for the hip, but we don't have that yet. So we're going to stick to the straightforward joints that are near the skin. The indications, just like I was saying, the different pathologies that we can see in all of these joints are listed here, but they're not exclusive by any manner. We are able to pick up more and more as we're getting better and better with doing these scopes. So before I continue with this is one of my colleagues doing an actual in-office arthroscopy. Not everybody likes to watch these things, okay? Some people get very queasy. They see a needle go into the body and they pass out, and I had one patient do that in my office. That's fine, that's normal. I don't really want to treat concussion today, so I will leave this to the end, and if anybody wants to watch the actual procedure, I'll show it to you, okay? All right, so science, basically how we do what we do. Why do we decide how we want to proceed with things? Everything is evidence-based. We can't just say, yeah, it works. Okay, take my word for it. We have to prove that it works. So we decided to do a study comparing the VisionScope arthroscopy to MRIs. And the two things that we looked at is how accurate are we, and are we actually saving money? Because, you know, you can't, in a perfect world, it wouldn't matter, but the reality is it matters in this world. So we compared patients who are having knee problems, who needed an MRI versus a VisionScope, and we had them do both. They had an MRI, they had a VisionScope, and they all had surgery, and that was what confirmed our findings on the VisionScope and the MRI. Then we looked at the cost effectiveness of it. We had 110 patients, of which were 18 to 75 years old, and we looked at their medial meniscus. And they all had clinical findings on physical exam consistent with that problem. And then we looked at how often was the VisionScope right, how often was the MRI right. And when we went to the surgery, we looked back and saw that the VisionScope nailed it this many times, MRI nailed it this many times, and then we looked at the cost effectiveness of it. Our findings from that were clearly that the VisionScope, which is in the blue here, picked up the tears much more reliably than the MRI. That's not a surprise. I mean, it's a camera as opposed to, you know, a bunch of magnets that spin electrons. I don't even know exactly what happens when you go into an MRI, but that's what it does, and it shoots out an image, and we try to figure out what that means. I can teach anybody in this room how to look at a VisionScope and tell me if there's a tear or not. It's that easy. It's straightforward. The key is that, one, it's safe. We have not had any issues with it. And two, if you're willing to go through the procedure, which is have a needle in your knee, it is a clear option. Okay? So let's look at cost savings. This is what we have extrapolated as numbers, which are unbelievably huge, if we went and replaced MRIs completely. I don't think this is where we're going. I don't think it will be replacing MRIs. I think it'll be an adjunct. I think it'll give you an option for the right patient, and the right patient is, something that we have to discuss with everybody that is interested in having it done. But for the vast majority of people, it's a wonderful option. So let's look at this. How does this work? So before VisionScope, you would usually see your primary care doctor or get a phone call and say, I need to see an orthopedic. You would come in and see one of us, and we would say, all right, we examine you. This is what I think is going on in your knee or your shoulder. I think you need to get an MRI. So then you get an MRI. Half the time that you get an MRI, at least in the shoulder, you're getting a needle shot anyway. Then you have to make another appointment to come back and read the MRI with us. Then we think you need surgery, so we go and we take you to surgery. Then you come back to see us after surgery. And then if things are going well, great. If not, then we have to talk about another MRI. Well, that's a lot of visits. It's one of those things where the more variables, the more things that can go wrong. I mean, if any of the patients in this room have had me as a doctor, I like to be there for my patients, but unfortunately some people fall in, they break their arm, and next thing I know, I'm not in clinic, I'm in the operating room. So you miss one of these. So if you only had 3 of these, you're less likely to miss one than if you have 7. Or somebody forgets, or something happens. So there's a lot of visits that we can cut down on. Now, your primary care sends you to see one of us. If we can, we've had the ability to, on that very day, put you into the procedure room, put the VisionScope in, and say, yeah, I had my physical exam says you have a injury to your biceps tendon. We'll put the VisionScope in later this afternoon. You go have lunch, you come back, we do the VisionScope. It's torn. If you need surgery, we can organize that for you. We just cut that in almost half your visits. Now, I'll be honest with you, it doesn't always happen that smoothly. That's like a perfect world scenario, right? I mean, there's this ugly word I hate to use, and it's called insurance. And they feel like they should have a say, unfortunately. So they do require us sometimes to ask them their permission if we can do our job, and then once we get their permission, we bring you back for the VisionScope. So, but as you can see, even then, it still cuts down on at least 2 visits. So again, we can see exactly the pathology that we're looking at. Here's one of my personal cases. So this is a very pleasant woman who came in with knee pain. She was claustrophobic, deathly afraid of going into an MRI. So I offered this to her. This, again, is a clear meniscal tear, okay? This is the VisionScope live feed going on here. And you can see normal meniscus up here, and this is all the damage and the tearing there. So that day, I booked her for the procedure. I took her to the operating room. That's what it looks like on a regular scope. Took care of the problem. 3 visits and done, okay? Normally, I mean, this would have been dragged on for a week or 2. I mean, sorry, a month or 2. And we were able to take care of this in literally a week or 2. So here's a knee where we had another situation. This is a pleasant lady who I'd operated on her husband, 3 joints, which is one of my highest number for one person. And his wife was having knee pain. And exam was confusing, MRI was negative. They were getting ready to have surgery because they were convinced they needed surgery. And I said, well, slow down. Why don't we take a look first? We went in there. Perfect cartilage, normal meniscus, no tear, no surgery, physical therapy, and saved her a visit to the operating room. Here's the bad news. If you go to the operating room, whether I do anything or not, you're getting charged the same. So if you can avoid it, I recommend it. So this is a shoulder. Now, some people, I look at this all day. If you guys don't want to watch this, it may make you a little squeamish. I totally understand. But what we're looking at is the top of the shoulder ball. This here is one of the front rotator cuff tendons. You can see the biceps starting right about here, and then here's the socket of the shoulder. It's a little bright. And what I will do is I'll pan over. This is your biceps tendon right up here. And what I was looking at on my exam, I'd seen this patient a few days earlier. She was complaining of pain with certain movements that made me concerned that she had damaged her bicep. Biceps tendon is right here, looks pretty good. You see some inflammation, that's what the red stuff is, and this is the underside of her rotator cuff. So this VisionScope confirmed to me that her rotator cuff was not torn, which was very helpful, because with an intact rotator cuff and a partially damaged biceps, my protocol is to give you a cortisone injection. You already got a needle in your knee, in your shoulder right now while I'm doing this. So guess what? I just put the cortisone in right through that. So you don't even have to have another injection. And then she went to physical therapy, no surgery. So no MRI even needed. So this was an interesting one. This is a one of my partners had this 20-year-old Division I soccer player. Was having knee problems. They had an MRI. The MRI was negative. They said there was nothing wrong with her knee. And they were planning on doing physical therapy and trying to get her back to playing. They decided to do the VisionScope, and they found a loose body. Now, a loose body in a knee is an absolute indication for surgery. That's a black and white. Even the insurance companies won't fight with us on that. Because when you try to do any kind of exercises, whether it's playing a sport, soccer, or physical therapy, and you have something like that floating around in your knee, it's going to wreak havoc in your knee. It's like having a piece of gravel in your shoe. It's going to scratch up all the cartilage on either side of it. And she would have ended up having surgery eventually because she wouldn't have gotten better with therapy. But we saved her that by getting the VisionScope and seeing that loose body, taking her to surgery, removing that, and then getting her back. So a loose body is when you have something floating around in your knee that's probably come off a piece of cartilage. It's not supposed to be there free floating, and it needs to come out because it can't go anywhere. It's stuck in your joint. So in this situation, a VisionScope overturned an MRI finding of normal knee, required surgery, and pretty much saved her soccer career as a result. So bottom line, we can see a lot with these new fancy tools. They are definitely changing our approach to things, allowing us to make more accurate diagnoses. Do they work for everybody? They don't. There's definitely a selection process in it, but when appropriate, I think that we can significantly save time, significantly save money, has frustration for patients, and give them diagnoses on the spot that we've never been able to do before. So, Dr. Novak and I are both here to answer any questions if you guys have any. Yes.
I don't know anything about these joints, but in the shoulder in particular, would you ever have to go in at more than one spot when you're doing this, or can you just go in one location?
We only go in one location. There's a standard portal that we put the needle in to look around. Getting in it's a talent, to be honest with you. For that reason, VisionScope has not even provided this instrumentation to everybody. So you have to prove that you are capable arthroscopically before you're allowed to use this, because otherwise it's not fun.
But you can get it in and
yes.
You can see a whole joint, all sides of a whole joint. Just
yes and no. So in the shoulder, you can see everything in the shoulder joint. You cannot see above the rotator cuff all that clearly because there's bursal tissue there, okay? In the knee, you can see two compartments quite well. If you get lucky, you can sometimes see the anterior cruciate, but there is anatomy in that area that can cloud your picture. But for the things that we are using it for right now, we're pretty good at seeing what we want to see. Sure.
And they're coming out with new scopes that have better angles on them, which allows you to get to see better pictures of different parts of the knee. And that's coming out very soon, I think. Yeah.
Yes?
My wife and I are both core physician patients. What's your goal in this presentation?
My goal in this presentation is to educate people that there's a new technology that we have, and we want people to be aware of it. So,
Or presumably you will offer that.
I'm doing this now. I've done 50 of these already. Yeah, these were my cases. These are,
I understand that.
yeah.
But is this technique available through any core physician orthopedic surgeon?
No, the only two people who are doing it are in this room right now.
This what?
The only two people are myself and Dr. Novak who are able to do this
But
right
you
now.
are core physicians?
We are,
Yes.
absolutely. Yes.
Is it similar to getting like orthodisc injections for the knee, for example, or is it more involved in that?
It's similar, very similar. We do have to numb up the knee a little bit before, yes.
I like to hear that.
Yeah, yeah. We don't want it to be uncomfortable, so we do want to numb it up. We let it set up, and then after that portion of it, yeah, it's just more time.
Yeah.
So, we're trying to look around.
How long does it take?
On average, 15 minutes.
And the same with the shoulder, or is
Yeah.
the shoulder a little more?
Honestly, the shoulder's almost a little easier.
I have shoulder and knee, so.
Yeah, The shoulder is a bigger joint, so we're able to actually get in there a little easier sometimes. Yeah. And there's less, believe it or not, inside the shoulder joint, there's less tissue that obstructs our view. So sometimes we get better views in the shoulder than the knee, but yeah, it's variable.
How long have you been doing this now?
We started the process back last fall, and we really started getting good at it and going with it for about the last 3 months. Yeah. Yes.
Patients on blood thinners like Plavix.
Great question. Yeah. You know, it has not been an issue. We have been doing injections into people on blood thinners for a long period of time without any difficulty. You know, it still warrant a conversation. Depends on what the purpose of it is. For example, if I was really looking for a meniscal tear, I would tell you, yeah, you know, I think it's worth a try, but if there's a lot of blood clouding the picture, I won't get a great picture. When we did cortisone injections into the shoulder, historically you would have to go to radiology, you would have to get an x-ray, they'd have to put a needle in, they would take another x-ray, then they would inject dye, take another x-ray, and then inject the cortisone. So in this situation, we put the camera in, we know we're in the shoulder because we can see it, and then we give you the cortisone. If it's bloody or you have more bleeding than the average patient because of your blood thinner, that doesn't affect it. We know we're in the shoulder. We may not be able to take crystal clear pictures like you saw today, but that's not the purpose of us being in there. The purpose is just so that we can guide our injection. And for that purpose, it's fine.
How do you go about selecting certain patients for doing the VisionScope versus an MRI?
It depends on what I'm looking for, first of all. So it depends on what my physical exam points me towards. So, you know, nothing replaces that, history and physical. The pathology that I'm concerned about is, number one, what prompts me whether to lean towards MRI or VisionScope. Secondly, patient preference. Some people are deathly afraid of needles. They don't want a needle if they don't have to. They'd rather have an MRI. That's fine. And then lastly, you know, a part of it that has to be discussed is patient size and anatomy. Some patients, unfortunately, have challenging joints, and it's just not possible to put these in there. So, and you know, if that's the case, I'm not going to torture somebody by trying to get it in when it's not likely to work. Yeah?
Does cortisone solve the problem or just mask?
That's a great question. The question is, does cortisone solve the problem or mask the problem? And the answer to that, it depends on the pathology that we're addressing. So in some circumstances, it solves the problem to the point where other modalities, like physical therapy, can help prevent it from ever coming back. So if it's purely an inflammation, a bursitis, for example, the cortisone gets rid of the bursitis, and the physical therapy prevents it from coming back. Now, certain things we can't make go away, like arthritis, and that masks it. So that's why you have more than one in those situations. So it really depends on why you're getting the cortisone. Cortisone is an anti-inflammatory, and pretty much anything that irritates the body causes inflammation. So that's why you get cortisone. Whether it cures it or just holds it at bay depends on what we're dealing with. Yeah?
Yes, great doctor.
Thanks.
Yes,
One of my patients. I've got plants everywhere.
I would just love to hear your professional description of the catching and blocking of the knee on that 20-year-old patient.
The one with the loose body? Yeah. So usually the description is, you know, I will be going along, doing whatever I want, and then I can't straighten my knee. And then I'll wiggle it or move it around, and then something will move, and then I can get it straight, or vice versa. I feel like something's stuck, and I can't bend it as far as I usually can. And then after a few minutes of like poking and prodding my knee, I get something to slip out, and then I can bend it again. That's what people usually describe with a loose body in the knee.